Dr. Samir, can you confirm when we see the slides?
Yeah, your slides are visible, Dr. Om.
Thank you so much. So once again, this is the CaReMe Pro 2025, and this is very thankfully, a great way. It's sponsored by Zydus Healthcare, by the Dapaglin division. It's fantastic for their and it's a completely, the editorial freedom has been completely given to us. There is, so it's a great collaboration we are having with them. Uh, if you had joined us last time, you are well aware of how we are going to go about in this program. So you have two ways in which you are accessing the program. One is through the live webinar, which we are having right now, and you can access the same. So we'll have the recording to the same available on the technochronology.com platform. The link you'll receive at the end of the presentation in your emails if you're registered through Zoom. We'll also be sharing it in the chat as well. So what we have done is the idea here is to see the long road of the patient, the long-term journey of the patient, how from where they start to where they eventually end up. Because when we are, learning medicine, we often see very short periods of time in our residencies, in our training. It's generally 3 years time when we see, patients from start to finish. But in real life and in real life practice, we have to see the patients for a long, long time. Some of them, part of our own community, friends, family, etc. So that's the whole idea, to see how the journey of a patient really goes through a long period of time. And again, we are going to have 4 Harvard Business Review style case reports. The first one you read, the second one we have put in the chat. You can download it and you can read it. It's like a story, right? But it's like a medical story of a patient, and that's what we're going to do. And then today, in this live session, we are going to discuss the actual story of the patient with our expert today. I'm going to introduce him in a few minutes. We have Dr. Srinivas Kudva. Thank you so much for joining. And it's going to be interactive. So there are going to be some poll questions. We'll take your view on those polls. We'll be discussing the same with our expert today. At the same time, if you have any question, please feel free to ask them during the session as well, but please put it in the chat. We'll be taking these questions during our interaction. And if you have any questions at the end, we'll allow you to speak as well. We'll allow some of you to speak and then ask your questions live as well. So that's something we'll be doing. Some of you would have joined us through the live web stream on our Endocrinology India YouTube channel. So again, thank you all for joining there as well. Okay. So these are the series. We already had the first earlier one on 1st of May, and now this is the second one. We are going to look at the life of a patient with heart failure. And then we are going to have the discussion next week with a nephrologist, and then we'll go to a case of a patient with an MSLD, which we'll be discussing with a hepatologist or endocrinologist there as well. Okay, and we follow what we call it as the technochronology way. So we have three ways in which we learn. So the Shravan is where you imbibe the material which is given to you, the learnings, the lessons, the discussions. Manan is that on the technochronology.com platform, you can there'll be a quiz, so you can answer that quiz. The quiz are again real life case scenarios, so it will be like a clinical vignette type of cases where you can answer this from whatever you learned in our discussion today. And then we have something called Nidhi Asan, which is basically reflecting on what you learned. So you can then put your reflection, and you can make a little bit of a template for what you can use in your practice from what you learned in our discussions. So that's the whole idea. Now you can access the course presentations and videos through this QR code. We'll also be putting the link here, and in a few minutes you'll receive the same on your email after the presentation is over. It's an online learning platform called technochronology.com where you have comprehensive resources. We had some other programs also along with Zydus Pharma. We already had a MSLD series of lectures which also went very well. This is the link. So it's technochronology.com or technochronology.thinkifit.com. Or you can directly go to technochronology.com/courses/CaReMe Pro, or you can just go to technochronology.com and the CaReMe Pro logo will be there. So you can click on that and enroll for the same. You will also be getting a certification at the end of the 4 parts, and you'll get a physical certificate also from Zydus. So you can contact your local pharma representative for the same at the end of the 4 sessions. So proud privilege of having with us our today's expert, Dr. Srinivas Kudva. Now, Dr. Srinivas I'll just give you his brief introduction. He's a well-known interventional cardiologist, and he specializes in complex coronary angioplasty and valve replacements. So you have now, you're in an era where you're super specialist and you're super duper specialist. So Dr. Kudva can be classified as a super duper specialist. He practices in Worli in the name of Guru Krupa ENT and Cardiac Center, the angioplasty and valve experts. And he has patients from all over Mumbai and all over the country visiting him. He also works with several reputed hospitals like Lilavati, EHN Reliance, Breach Candy, Wockard, and others. And Dr. Srinivas has completed his internal medicine from KS Hegde Medical College from Mangalore. He was the best outgoing student there. He's also done his DNB in cardiology from Lilavati. And he's also a fellow of the American Association of Cardiology. He's been practicing since 2014 and has more than 8 years of experience in critical care medicine, heart failure, critical care cardiology, and is known for his patient-centric approach, efficient management of emergency and complex situations, and is an expert in valves and heart failure, right? So am I right, Dr. Srinivas? Yeah. Okay.
So, well, I'm super duper humbled at the very, very kind words that you have used for me, and I'm very grateful to Zydus for this opportunity.
Thank you. Thank you so much. So, Dr. Srinivas will be beginning the case. So, just give me a minute to share the case as well, and then we'll start the discussion on the same. Okay. Right. So the case we have titled today, Mending Hearts, cardiology, heart failure. I think that's a very important era. In fact, today is the 2020s are era of heart failure treatment, right? I think a lot of interest in heart failure management has come, and SGLT2 plays a very pivotal role in that, especially in patients with diabetes. So this is a case of a patient called Arjun Sharma. It actually mimics a real life patient, who follows with us for a while. Now, when he first came to the medical attention, he was 38 years old. He was working as an IT project manager. And then, he had already had diabetes since the last 5 years before, and these days we see patients in 30s with diabetes very commonly. It's become a norm. So he had type 2 diabetes somewhere in his early 30s. And he came to us with an HbA1c of 7.8. He was having hypertension on an ACE inhibitor. He was in dyslipidemia as well on atorvastatin, obesity with a BMI of 32, has a sedentary life, limited physical activity. Of course, important history, a lot of importance given to heart in cardiology with the family history as well. And he had a father who had a myocardial infarction at the age of 55. So this is the overall case summary. And when he came to us, he had progressive exertional dyspnea since the last 6 months. In fact, he literally was, dyspneic when he walked in. He had fatigue and occasional ankle swelling. Blood pressure was 145/88. GVP was not elevated then, but he had mild bilateral ankle edema, clear lungs. And then we set his investigations. And then he had an ECG, which showed an LVH criteria. The NT-proBNP was elevated. Echo showed a LVEF of 55% with diastolic dysfunction and LA enlargement, and HbA1c of 7.6 with an EGFR of more than 90. So we label him as type 2 diabetes, hypertension, obesity with an HFpEF, right? And this HFpEF is an area where, it's again a term which probably 20 years back not many people heard about it, but it's a disease which is kind of now being emerging as a very important area of presentation. So Dr. Srinivas, your take here on the initial clinical presentation. I'm sure you would have seen an Arjun Sharma probably today in your practice as well. It's a very common presentation of a typical patient which you see in practice.
So unfortunately, I saw someone even more critical, 42-year-old male.
Okay.
This is real life story I'm telling you, few hours.
Okay.
42-year-old male. He came to the clinic with loose stool since 2 days and uneasy sensation after having food a week back.
Okay.
He came heart rate of 130, pedal edema. He was referred by a family friend. So he said, Doc, I'm uncomfortable since a week. I'm
Right.
sorry, I've been arrogant, ignorant, and I have been very, very uh, irresponsible with my health.
Mhm.
I'm not feeling well. And this is a real story. Yeah? He's currently in ICU.
Okay.
His heart rate was 124. The SATs was 90. Checked his BP, it was 70 systolic.
Okay.
And ECG showed QRBBMI
Mhm.
with the EF of 10%.
Okay.
His sugar,
42-year-old, right? Yeah.
42-year-old. He
Yeah.
has a 7-year-old daughter.
Wow.
2 days back, he had gone to her dance recital in
Right.
school.
Mm.
And his random sugar of 470,
Wow.
told to have some high sugar, but he has not got. And to one pulmonary edema. Um, this is a real life story.
Wow.
And his EF is only 10 to 15%.
Wow.
So QRBBMI on the ECG, but EF, the anterior wall is completely burnt out.
Mm.
And he has 3 relatives who are senior doctors in different
Wow.
parts of the country.
Right.
Yes, his real elder sister is a doctor practicing for the past 15 years in Karnataka.
Wow. Okay.
So what I'm trying to tell you is
These are
cardiac
real patients, right? I mean, this is,
real
yeah.
patient.
So this is, yeah, this is, mm.
So even in this patient, like who we are discussing,
Mm.
the first thing that you need to realize is the age.
Right.
Heart disease is now something which is much more common
Absolutely.
from the age of 30 onwards. And why it is, you cannot blame COVID and you cannot blame your genes.
Right.
That is the last which is there. What you need to realize is our substrate. Food is a number one issue where we keep poisoning ourselves
Right.
with trans fats, with all kinds of packaged foods. And we are exposed to adulterated food and a lot of radiation. Every house
Mm.
has Wi-Fi. All of us has 2, 3 mobile phones, 2, 3 SIMs. So all of us are working 24/7.
Mm.
It's not about roti kapda makan. It's about roti kapda makan, Mercedes Benz, Apple iPhone, and Rolex watch nowadays.
True. True.
So we are all burning the candle at both ends. So youngsters are more,
Right.
you know, मिनट नूडल खा के जेप्टो जोमेटो से ऑर्डर करके बाहर का खाना खा के नींद ना लेके वी आर नॉट स्लीपिंग 8 आवर्स.
Right.
हम 10% की बैटरी पे 100% का काम करवाते हैं, तो तकलीफ
Mm.
होगा ही.
Absolutely. Great, starting story. I think that's very telling. Arjun is going to be the next, at 42, he'll probably, if, it didn't come at 38, he would have gone, he would have been the, guy you talked about. And then, very rightly said, this is so Arjun, though, presented a little bit earlier, but he's going to go in that path, right? He's going to go in the path which you said, right? This is how it is. So, how much importance do you give to something like an NT-proBNP? Fast emerging is a very important, a marker in especially in these kind of patients. How much importance do you give to an NT-proBNP when a patient first walks in with this type of presentation?
So getting to Arjun now,
Hmm.
issues, bullet points.
Hmm.
Heart failure with preserved ejection fraction is as common as heart failure with reduced ejection fraction.
Correct.
3 types of heart failures: heart failure less than 40, 40 to 50, more than 50.
Hmm.
More than 50 is preserved ejection fraction. NT-proBNP is essential as a prognostic marker and a diagnostic marker. If
Correct.
you don't have other comorbidities, if you present with this, for example, an NT-proBNP of 600, 700 with kidney failure is expected and normal.
Right.
But with EGFR more than 90 and getting an NT-proBNP of 450 is still high.
Hmm. Okay.
So you have to look at the other parameters as well.
Right.
In
Right.
this
So again,
gentleman, you have, sorry, you
yeah,
have a
please
high
go ahead.
BP, which is
Hmm.
uncontrolled. At
Hmm.
his age,
Hmm.
I would want a BP of 120. He has
Absolutely.
an ECG on ECG showing LVH.
Hmm.
Most probably the 2D echo, apart from the normal EF, is also showing a grade 2 diastolic dysfunction with the LA, which is enlarged. So he has long-standing uncontrolled blood pressure, which has added to the diastolic dysfunction. And the obesity, which I feel is also adding to the diastolic dysfunction, and the diabetes is adding to the diastolic dysfunction. On top of that, an important thing that has to be worked out in this for Arjun is obstructive sleep apnea. That
Great.
obesity will be adding to the obstructive sleep apnea, which again adds on to the diastolic dysfunction.
Absolutely. Great points, I think. So I think that's and a very important learning point, again, that, look, at least ask them questions for an OSA, right? So I think that's a great point. So just a quick audience poll here. So I'll just run some polls in the middle, and then, if you have, the audience, please input your points through while we discuss the same with, Dr. Srinivas. So, the question here, sir, is that most of the, for this patient, now you saw the profile of this patient, right? Immediate first step as a cardiologist, again, from a cardiologist perspective, what would you do? So, intensifies glycemic control. He is having an HbA1c of 7.8. It says here insulin, but of course, there are, of course, other medications you can consider using. Would you add him something like a torsemide, a loop diuretic? Would you increase his ACE inhibitor dose? And of course, optimize his lifestyle, or would you initiate him on an SGLT2? So at this point, I mean, if you had to choose one, obviously, last time also Gagan Priya, she said everything, I'll do all, right? You probably say all, but if you had to choose one,
No, I
okay,
will definitely not say all, and I'll tell you why.
okay, tell me. Great.
So my first go-to would be to use dapagliflozin, okay?
Okay, right.
SGLT2 inhibitor number one.
Absolutely.
And I'll tell you why. Because it will get down the NT-proBNP. It will also get down the blood pressure slightly. It will also give you better glycemic control.
Absolutely.
Okay. Number two, why not increase perindopril dose? Because it does not help in HFpEF. It might help in getting the BP down.
Right.
Be honest, I would stop the perindopril. And if the patient is slightly more affording, I would start off with Arnex. I would
Right.
start off with a good dose of sacubitril valsartan, because
Great.
all the studies have shown that even though it does not help in increasing the lifespan per se, but the quality of life definitely improves. There is no doubt about that. So I would go on to use a sacubitril valsartan for HFpEF. So I would use Arnex. Number three, I would not use a loop diuretic because that would not really help much in the long run. I would use something like a Finrenone,
Right.
which now the FINART study has shown Finrenone is a newer version of an mineralocorticoid receptor antagonist. Um, or if the patient is not that affording for a Finrenone, I would go in for a simple aldactone,
Right.
or I would go in for an eplerenone.
Right. So
Because
MRA should be a
a
part of this treatment, right?
mineralocorticoid receptor antagonist, which will
Absolutely.
have all remodeling properties, which is
Hmm.
known to help with HFpEF. So
Absolutely.
aldactone was first seen in the TopCat trial, which it helped with HFpEF. And now we have the SGLT2 inhibitors, which help with HFpEF. So again, that would be a go-to drug. And obviously, intensifying glycemic control, but without insulin in him, because we have multiple drugs now. And in
Right.
such a patient, I would rather have more aggressive lifestyle modification, more aggressive diet control, and oral medications rather than adding insulin.
Okay, absolutely. Great point. Great pulse. I think I love the clarity of thought. So let me just summarize. SGLT2, absolutely, right?
Yes.
Without blinking, we'll probably put an SGLT2. Sacubitril valsartan, again, great, addition. Again, let's forget that. Let's assume that he has a Mercedes-Benz which he can sell. So, cost is not an issue. Finrenone, great. So MRA. So these are your three go-to drugs you'll add straight away for Arjun, and I think again great points to add, right? So, and interestingly, the audience completely agrees with you. 71% overwhelming number do agree that, SGLT2 should be the probably the best answer. We are all given that multiple choice question exams, all our life. We're used to get one best answer kind of thing. So I think, they all completely agree with you. Okay, so moving on, let's then look at his journey. Okay, so unfortunately, the doctor who saw them was not Dr. Srinivas. Whosoever saw him optimized his perindoprine at that age. Metformin was continued. Lifestyle was reinforced, as you rightly said. Torsemide was added, which is, this is what you see in real life practice. This is what happens, right? And this is the thing, and that's why learning is very important, right? Cross specialty learning. And then, you had some modest improvement in the symptoms. The blood pressure control was there. HbA1c reduced a bit. NT-proBNP was around that, right? So I think, they did what probably, a lot of people tend to do. So I think, it makes sense that, probably we need to upgrade our thinking as well. So I think that makes complete sense. And I think you answered all of these points, probably not all, but you would be selective in what you choose here. Okay. Now, then let's move on. What happened to him in his 40? Now, the interesting point, Dr. Srinivas, is, like I said, Arjun is going to be your patient at 40. So he's the guy who exactly presented, like you said, right? So he had an acute event. Okay, so Arjun experienced sudden onset of chest pain, shortness of breath while working late, very similar to what you said. Presented to the emergency with an acute anterior wall MI. ST elevation MI, went for a PCI, a successful stenting was done of proximal LAD. Hospital course was complicated by the cardiogenic shock, temporary inotropic. I'm sure, again, this is, you saw probably another Arjun also maybe a day or two back, right? And an echo showed a EF of 30, anterior wall akinesis, heart failure with reduced, basically MI, right? So, what's your take now? So I think, I think you predicted this, which is uncanny, but, this is exactly what happened to him. So, yeah.
Okay. Just a 2 minute, another story deviation.
Yes.
So first, I'll
Hey,
put a
so
disclosure.
Srinivas, we love stories, right?
Huh.
So this is the thing. So idea is that we learn from stories, and that is exactly what we. So please feel free.
So the first disclaimer is I have never seen these slides before.
Yeah, which is the telling point. Great.
Yes, that's the uncanny part. But
Yes.
so my youngest heart attack patient with a QRBB anterior wall MI has been an 18-year-old boy.
Oh, okay.
And so very well-to-do family. In fact, IAS, IFS parents, when I saw the ECG, he went rushing in night, discussed with the family saying he's had an MI. The parents were in shock. They were like, he's not even had a first shave. How is he gotten a heart attack? I said, we'll get to all of that later on, but now I need to take him in because his heart pumping was 20 to 25%. Took him into the cath lab, did a thrombosuction, opened up the LAD, proximal LAD. Just when I was going to put a stent, that time the little boy starts crying. And then I asked him, are you getting pain in your hand where I'm doing the angioplasty from? And he's like, no, sir. And then I asked, is your chest paining? What is happening? Why are you crying? So he said, no, sir, my chest is not paining. So I told him, I'm going to position stent now. You cannot afford to move like this. Tell me why are you crying so that I can, address that. And he looks at me and he goes, sir, please don't tell my parents I did cocaine today.
Oh, okay.
And so this was basically a plaque rupture because of cocaine use in an
Right.
18-year-old boy who
Right.
was very wealthy and who is very wealthy. Thankfully, he's doing better now. His heart pumping has improved to 40%. But still, it'll never be normal because it was QRBBMI. So he's got a lot of damage to the heart muscle. But
Already, yeah.
yeah, so we also have to watch for lifestyle modification and all the other risk factors.
Great
Yeah,
point. Great point.
because-
I think, so that's something which often, we miss out in the history as well. I think it's very important, important pearl again, to really look into. Great. So I think, that's the point. So again, to the audience, if you have a question, what I'll suggest is please don't raise your hand. Just put it in the chat so that we can take it as we are discussing, and then we can kind of, allow you to ask your question, there. So we have, Sir, Dr. Ramaswamy has asked, that whether a resting tachycardia helps in your diagnostic algorithm in terms of HFpEF or any other way, So you stressed upon this, and you had a patient with resting tachycardia. Does that really aid to your diagnosis?
So it definitely does. That's a
Mm,
beautiful question. But the problem with the heart disease is it's not 1:1 like how mosquitoes cause malaria. So
correct.
you cannot have a direct spinal reflex correlation. You
Mm,
have to involve the cerebral cortex and have a thought to it.
mm,
Because once we had a young patient with no other issues and just tachycardia, and it turned out to be retroviral positive, and that was the cause
mm,
of that because the patient had PCP infection.
mm, right.
So that is one of the thing. Tachycardia can also be because of only anxiety. If the
Mm,
patient is not in a fluid overload state, not having pedal edema, no fine early basal creps, and that's not failure, then the patient will not be tachycardic.
right. So again,
So
yeah. So I think, great point. So I think maybe not rely just on clinical cues, but of course, a tachycardia being very important as well. So I think great issue. So again, reiterate. HFrEF is when you have LVF of less than 40. HFpEF is when you have 50, and then you have this new kid on the block, mid-range ejection fraction, which
mid-range,
is
and
so.
we discussed this
What's
already.
the fascination with sub-categorizing everything? Okay,
Yes.
so that's the thing. And NT-proBNP, we already discussed this. Again, just to remind everyone, Dr. Srinivas has not seen the slide, so I think it's an uncanny thing to really see that. I
Uncanny,
think
yeah.
yeah, absolutely. So again, this is the thing. So. You now saw Arjun had an MI, okay, and you saw his past as well. Now you are the treating cardiologist, and we did the PCI, and then he's not crying, thankfully, and then you're seeing him again at discharge. What are the things you will reinforce, and what are the things you'll do in terms of clinical
Okay.
management? Yeah.
So one thing is dual antiplatelets, that would be aspirin along with ticagrelol,
Okay.
and full dose tolerated statin therapy, probably either 80 mg of atorva or 40 mg of Zyrova.
Mhm.
So what you need to realize is, apart from this, you need to have the four pillars of heart failure.
Right.
Now that the EF is low, so you have studies which show that AC inhibitors are good, but and as good as sacubitril valsartan for
Right.
post MI cardiac remodeling.
Mm.
But one thing that AC inhibitor doesn't do is reduce left ventricular end diastolic pressure and act as a natriuresis diuresis.
Right.
So I will still go in and give sacubitril valsartan because it has all these other effects because of the neprilysin inhibition. So again,
Mm.
my go-to drug first would be a low-dose sacubitril valsartan. I would, before that, introduce a full dose of dapagliflozin 10 mg SGLT2 inhibitors. Also give a low-dose mineralocorticoid receptor antagonist, that is eplerenone or aldactone or finrenone. In this case, not finrenone because
Right.
low ejection fraction, the studies are still going on, but at least an aldactone or a eplerenone. Preferentially eplerenone because a young male and gynecomastia and all are much less.
Correct.
And eplerenone has this anterior wall remodeling cardiac properties. So the ballooning of the apex is much less. And I would also add a beta blocker because bisoprolol has to be given. Young male, I would give only bisoprolol. I love bisoprolol. I keep writing a lot of bisojoy, and you need to know why.
Mm.
Beautiful drug, more beta 1 cardioselective than even metoprolol and nebivolol.
Mm.
Um, Good, not very heavy on lowering blood pressure,
Mm.
no erectile dysfunction in male, safe in COPD and other asthmas, even in CKD patients, very safe because it is non-dialyzable drug. Arrhythmias are much less with bisoprolol, even safe in CLD patients. And low dose can be given 24-hour extended. The action is there, so you don't have to give it twice a day.
Mhm.
On top of that, the bio variability which is there in the patients, that is the pharmacokinetics and the pharmacodynamics of bisoprolol, is much more predictable. So that is why that would be my beta blocker of choice, especially in a young male.
Okay. So a great point. I think that's a great point. And yeah. So a couple of questions from the audience. Let's take the one which is common. A lot of there are two questions, both pointing to the same thing. there is a concern of hyperkalemia, right? At least,
Correct.
in terms of when you're prescribing a Findrenon or a eplerenone or a aldactone, so how common is it, and how, when do you watch for it, and what do you do with that?
So more often than not, hyperkalemia occurs when you're giving 200 mg of sacubitril valsartan with at least 50 mg of the mineralocorticoid receptor antagonist.
Okay,
If you're using 50 or 125 mg of the MRA, it's very rare.
right.
And even if hyperkalemia occurs after this, it is more commonly because of the diet. The patient is having coconut water daily, or banana, or that sort of thing. So diet control is better. And you can use potassium binding resins before stopping the drug because the effects are so much more better.
Right.
And that also, I wouldn't worry if after 5.5, then I would really consider it.
Right.
Otherwise, I
Absolutely.
would.
Yeah. In fact, Findrenon, you see very little
Very
hyperkalemia
less.
compared to the earlier generation as well. So I think, yeah, that's a great part. And Jan has asked that you talked about Findrenon. I mean, of course, now it's a different issue, but earlier he had basically HFpEF. So how much data do we have for Findrenon with HFpEF? Again, from a theoretical perspective,
So,
great. From a data perspective, how much knowledge so far we have gained
data
from?
perspective, fine art study was presented where it was proven that Findrenon is the drug of choice for HFpEF. So that will really help. It helps in cardiac remodeling, it helps in reducing morbidity and mortality. So that is now a drug of choice. Like how you have SGLT2 inhibitors as a drug of choice for HFpEF, like that Findrenon is now a drug of choice for HFpEF.
Absolutely. Great. So I think all great points. We'll take a few questions later. So now we'll just run a quick audience poll for you. And, I think somebody has asked from the audience about how fast you up titrate. Can you just clarify what you would up titrate, what you want to ask about? So you can just clarify in the chat. This is the poll question. So following his MI and diagnosis of HFrEF, now, I mean, of course, what medication class would be prioritized for Arjun along with existing ACE? I think you already answered this again, but MRAs, beta blockers, SGLT2, loop diuretics. Again, all fair points.
Okay.
And you'd
So
all
I'll-
say you probably said all because and again the choices are also a little different. I think that's a great learning point. Bisoprolol compared to metoprolol as the choice is given. You said MRAs great, very important. I think SGLT2, you are right off the bat that we'll start an SGLT2. Baki to sab dekhenge. And then again, loop diuretic, I don't know, it just keeps popping up. I'm sorry in these polls. So your take as, of course, multiple, but again,
First
like
full
multiple.
dose SGLT2.
Correct.
10
Okay.
mg dapagliflozin, easiest to start, very least side effects, maximum benefit.
Right.
So easiest to
Absolutely.
go to full dose as 10 mg dapagliflozin.
Right. Okay. So great. So basically maximum bang for buck, right? You get maximum benefit, all data driven benefit, very clearly. So again, the audience also, has a predominance towards prescribing an SGLT2. So yeah. Okay. So moving on. Dr. Ramaswamy has asked, what about GLP at this point? I mean, of course, maybe you see Arjun maybe after a couple of weeks. What's your take on GLP for a patient like this? On a follow-up, not at the time of
GLP-1
discharge.
RA?
GLP-1 RA, yes. Something like a
Beautiful.
semaglutide. Yeah.
Well, he'll have to sell his Mercedes and his home, but no,
Yes.
but it's a good drug, especially for weight loss,
Yes.
and it will have all the other benefits also.
Yeah.
So it's a very good drug, but it wouldn't be one of the first 4 pillars of heart failure, nor would it be the initial one to be initiated for the MI. But once he's stable, then I would definitely consider adding, depending on how the obesity and the weight loss and everything is.
Okay. Yeah. Yeah. Fair enough. Absolutely. Right. So, so perindopril for some reason was continued. Bisoprolol, right, was added. Spironolactone, atorvastatin, aspirin and clopidogrel. You said ticagrelor, right?
Because
What
ticagrelor has
perindopril?
100%
Sorry. Yeah.
stent patency. So
Yeah.
ticagrelor is now having zero stent thrombosis risk. Clopidogrel is now not used, especially for a young person. You want something with zero risk of stent
Correct.
thrombosis.
Great. You said you use sacubitril valsartan, which is again a very important point, which you beyond the thing. Again, somebody just continued metformin. I think probably this was an era where SGLT2 was probably still new. Maybe let's give that the benefit of doubt, and to keep the interest going, to when we'll add in DEPA, and then yet he continued to have symptoms. What happens is, in real life also now, of course, there's a lot of awareness about DEPA, and SGLT2 per se. It's being prescribed more, but I still remember, that the few initial period when it came, there's still hesitancy by a lot of people to prescribe that, right, including endocrinologists. So I think there was an era where probably this patient would have gone home with just a metformin or maybe a sitagliptin metformin. That is what would have happened. It's not that uncommon. Now it's of course difficult to imagine. He continued to have a very high NT-proBNP. Again, coming back to this point, because there's a lot of when we did a little bit of knowledge testing and a little bit of survey, a lot of interest in NT-proBNP. You talked about interpreting NT-proBNP in the context of his creatinine, his other clinical parameters. But per se, as a diabetic and an obese patient, how do you kind of really interpret NT-proBNPs in isolation when this is just a test which is being done as a part of the panel?
No. So in isolation, nothing can be, everything has to be taken with a pinch of salt.
Yeah, absolutely. Okay, great. So, and if we take just one more audience question here, Dr. Sanjeev has asked, if the patient, let's say this patient or anybody, he develops a atrial a flutter or a fibrillation with a HFpEF, what is the drug of choice then? Because it's a little diverted from the topic, but since we have the cardiologist, we'll make the best use of cardiologist. So,
so it depends. See, if
Yes.
its flutter is different, atrial fibrillation would be different.
Yes.
If it's post MI, if he's developed a flutter, then I would look at the hemodynamics. Now the thing is, flutters are very, very resistant to medical change, and the only thing they respond to is DC cardioversion.
Right.
Now the issue is, first I would try and correct the potassium. I would try and give magnesium, because hypokalemia and hypomagnesemia is the most common cause for either fibrillation or flutter. Number one.
Right.
Number two, given a choice, if ibutolide is available there, ibutolide is a drug that is used specifically only as a cardioversion drug. It is used in chemical cardioversion. The name, the brand available internationally is Fibricor. There is only one company that has it. In fact, uncanny as it is, I think I have done around 25 chemical cardioversions with Fibricor. I have done a study on that. I've not published it, but I think I'm the only cardiologist who has done that, along with Dr. Prakash Sansgiri, who is still one of my teachers. He's very senior to me. But 25 patients I have personally used Fibricor, and it is used only as a chemical cardioversion drug. Now the thing is, post MI, I would not go to DC cardiovert the person, because the chances for ventricular rupture increases tenfold because of the damage to the myocardium. So if Fibricor is available, use that. It's a beautiful drug to cardiovert, and then you can give your standard beta blockers. And if atrial fibrillation is there, the thing is, when the left ventricular ejection fraction is low and the patient develops atrial fibrillation, the atrial kick is lost and the effective LVEF drops by 25%. So there will be a significant hemodynamic compromise. In that case, if you do not have Fibricor, and if there is a hemodynamic compromise, then the only thing to do would be a DC cardioversion.
Right.
Okay. Since it is a new onset one, it is still a risky thing to do. But if there is hemodynamic compromise, if no hemodynamic compromise, then I would go in for anticoagulation along with dual antiplatelets and rate control with the beta blocker. And not with diltiazem or verapamil or that sort of thing, because that will push the patient more into heart failure.
Okay. Great.
And using digoxin in such a patient with the post-MI status increases ventricular rupture. So you have to balance between a frying pan and,
Yeah,
the fire.
another frying pan.
Yeah.
So yeah, absolutely. Great. So yeah, so I think moving ahead with SGLT2, great points here. That was a little off topic, but thank you for covering this. So eventually this patient, should have been on dapagliflozin 10 milligram, and he was put on the same. Heart failure with reduced ejection fraction, we all know the role of SGLT2. I think there is no doubt about it, about this. Of course, improves the cardiac energetics, the cardiac fibrosis, even, the remodeling here also there's been seen to reduce anti-inflammatory action, improves the myocardial function. Of course, renal function monitoring, not that much of a problem generally. In fact, renal preservation. In fact, there are less risk of AKI on patients with on an SGLT2. Risk of genital mycotic infection, which is very, very minor. Volume status, euglycemic decay, if you use it in the wrong patient, but generally, not in these patients. And again, patient education of side effects. So I think, Dr. Srinivas, I think you very right at the front, you said about SGLT2. Just a quick word on your experience, little experience sharing with SGLT2 in such patients where you use them.
Okay. So SGLT2 is a beautiful drug which is here to stay. Whether any kind of heart failure, reduced, mid-range or HFpEF, has to be used for its cardiac dose. It helps both at the molecular level and on the gross level. I think my loop diuretic usage has gone down by almost 90% with all the newer drugs which are there. Along with the fibrosis, the reduction in preload, helping in the afterload, anti-inflammatory, beautiful, beautiful drug. Now, I would like to play the devil's advocate and add where I would not use the SGLT2 inhibitor. Number one, if the patient was acidotic, because SGLT2 can cause euglycemic ketosis. Because of ketosis, it can cause acidosis. Okay, that is number one. Number two, if the patient has a triple vessel disease and I have to send the patient for a CABGS, then I will not give SGLT2 inhibitors. Okay. Number three, if the patient is a morbidly obese, very old female with a history of recurrent urinary tract infections, with a history of sepsis, I will not use SGLT2 inhibitors. And number four, which is very, very debatable, if the patient has a history of severe osteoporosis with multiple fractures, then you tend to avoid it. But the thing is, SGLT2 inhibitors is here to stay, and it is here for us to use in order to help reduce the morbidity and reduce the mortality for our patients.
Great. Right. So, so yeah, osteoporosis, I think now it's moving away. I think again, benefits far outweigh any concerns which we have. We'll take a couple of audience questions while we take the audience poll as well. So just give me a second to run the poll. Okay, so here's the poll for the audience. So what is the primary established benefit of adding an SGLT2 like dapagliflozin to standard, guidance-led medical care in patients like Arjun with LVF of 30% and type 2 diabetes? So would it mainly should your concern be to improve HbA1c? Should it be to reduce the risk of heart failure? Would it be to increase the LVEF, or would it be to normalize NT-proBNP? I think again, it's a very obvious answer. And I'm sure 100% will be going towards one side. So a couple of questions while we allow the audience to answer the poll. We have a question from from one of the guests who says that he or she probably wanted to ask about ARNI. So how fast would you up titrate ARNI, and what's your ARNI up titration protocol?
Depending on how stable the patient is, as long as the patient's blood pressure is more than 90 systolic, kidney function is fine, and potassium is okay, I aggressively up titrate.
Okay.
In fact, I call the patients every 10 days and I up titrate it.
So in weeks you just up titrate, yeah? Okay.
Yeah. So I think one of the companies did this study where they said that more than 80% of my patients are on full dose of ARNI, 200 mg twice a day. So they said
Yeah,
that's
yeah,
an
yeah, absolutely.
inhuman number because all over the world people stop mostly at 100 and only 20% is at 200, and they were wondering how come most of my patients, because what I do is as soon as I increase the ARNI dose, I increase their fluid intake also by 200 to 300 ml, and 90% of my patients are off loop diuretics, so I increase the fluid status, increase the ARNI, then they are like on cloud nine.
Right. And I think, one very important point you said earlier as well, I think which you picked up, improves the quality of life, both SGLT2 and ARNI. So I think that is something, yeah.
Unparalleled.
So if I have a neighbor, just who lives above me, who was in ARNI, and she's, I think, very, very rightly said. So I think, stories really tell a lot of things. Dr. Rajesh has asked about pioglitazone, which is not anybody's favorite cat. So I think pioglitazone would not be I think would be will stay away from that in a patient like Arjun for now, for sure, for multiple reasons. How early after a heart failure or a MI, how early after acute MI would you use all these four pillars? And I think you answered that by as early as possible, right? So,
So I'll
yeah,
play a
yes.
devil's advocate to that.
Hmm, hmm,
So
hmm,
I'm very close to Dr. Shashank Joshi and Dr.
hmm,
Vijay
hmm,
Panikar.
hmm.
They are both stalwarts in endocrinology and diabetology. And both of them were the one who got pioglitazone back into the market after the Indian government banned it.
Okay.
So the heart failure warning, yes, is there with rosiglitazone, and the PPAR alpha and gamma action of pioglitazone is what they advocated in and said that it helps in reducing insulin resistance, in reduction of many other issues, and that's how they got it back. So I'll tell you how I use my diabetics. So a lot of my patients don't prefer going to other doctors. If they are already going to many specialists, I let them continue. But some of them are like, doctor, you only please control it. So for those patients, what I do is SGLT2 inhibitors along with metformin, DPP4 inhibitors. It- Very few patients are on GLP-1 RAs because it's still very expensive. After that, I add Voglibose with ripaglinide, and then my go-to drug is pioglitazone. Because pioglitazone is beautiful. My last drug which I initiate is a sulfonylurea, because that has more side effects of hypoglycemia, and then you have to keep up titrating the drug because islet cell beta cells, they get exhausted. So that's how I go about it, and then insulin finally.
So, Srinivas, we wrote I was a student in endocrinology. There was a paper published. There was guidelines published on sulfonylureas. I've always been a very anti-sulfonylurea advocate for a long time. So I think I wrote a letter to editor that time, being a student, criticizing the guidelines, saying that in this era, why have a SU guideline? Basically, right? So where I sent a letter back from the editor saying that we generally don't, send letters to editors back, but please tone this down because it is too critical. Which is very interesting because the same editor who was there that time and the people who wrote the guidelines, things have changed so much that now, just like you said, SUs are again the last drug which a lot of people, use now. So yes, eras change, and I think, ideas change, sometimes being a little ahead of time is also not that great. We have a couple of questions from the audience. I will take that later. So the last two questions about UTI and other things, I think we'll take it with the nephrologist next week. So we have, we'll take that later. Today we have a cardiologist, so I think, we'll stick to more of a cardiology questions because, we'll be discussing SGLT2 ad nauseum, literally, for a while. So we'll take those questions in the next upcoming webinar. So please join us next week for that. And then, looking back at Arjun, he was then 42 when he came, and then he had, of course, after giving an SGLT2 and the other goal-directed medical therapies and ARNI, he had marked improvement in symptoms, the quality of life. He said he started feeling like himself again. NT-proBNP came down, I think, again, and a little obsession with NT-proBNP in this case. But yes, I lost a little bit of weight, and eGFR was pretty much stable. Again, we integrate everything in terms of the treatment. So again, you have patients' well-being, the NYHA grades also, and do you use this Kansas City cardiomyopathy questionnaires, and does it have value beyond research, in clinical practice?
No, it
These
really
questions?
helps because
Yeah,
patients
yeah,
themselves say, Doc, I'm feeling much better because they are
yeah.
objectifying, writing down what they
Yes.
feel to be.
Yes, great. So I think, at the end of the day, that's what patients want, they want to feel better. I mean, that's the ultimate goal, right? Yeah, so quality of life assessment, I think this is what we discussed, and you very rightly said, the great part about these newer drugs, actually, that they actually improve the patient's life, but they can do things which they couldn't for a while, go back to feeling normal. That's what we all want, we just want to live a normal life, I think, do the normal thing which a 42-year-old would do, uh, you know, uh, uh, generally. So that's the whole point, Yeah. So I think that's the thing. And again, we have, yeah. So we'll just take the last audience poll, and before we move to the last point, okay, just give me a second. This point, I will then take a few questions, and then we'll end the day. Okay, so just the last poll question to go about, and yes, so Arjun's quality of life improved. How do you interpret this choice? I think again, sometimes very obvious questions. So you can, well, please feel free to answer. But this Arjun showed improvement in quality of life. I think that makes sense. Again, beyond numbers, I think it's again a lot of things is in terms of patients' well-being as well. So this is the follow-up after things, the storm has passed away. You had Arjun, who is now on a DEPA with a metformin, which was continued. He has improvement in his clinical symptoms. He's better now. His ejection fraction has improved. So do you see this, Srinivas, in your practice? Improvement in EF with good medical therapy over a while?
Can I tell you a case I discussed with Dr.
Yes.
Yash Lokhandwala?
Yes.
There's a young male who was 30 years old.
Mhm.
He had come to me for putting in CRTD,
Okay.
cardiac resynchronization therapy with a defibrillator.
Mhm.
His EF was 30%. CT angio was normal. Cardiac MRI showed cardiomyopathy, non-ischemic dilated with the EF of 30%.
Mhm.
LBBB on ECG,
Mhm.
broad QRS complex.
Mhm.
Started sacubitril valsartan, dapagliflozin full, mineralocorticoid receptor antagonist of 50, and this beta blocker.
Right.
Told him we'll give him 6 months, and we will see how he does. And if he doesn't improve clinically, then we'll go in for a AICD. I mean for a CRTD. After I think 2 months, he came saying he's much better. All the swelling is gone. We did his ECG from a LBBB broad complex. He's come back to sinus rhythm normal.
Wow.
And the discussion, we repeated a cardiac MRI which showed completely normal left ventricular, left atrial dimensions, everything normal. His left ventricular end diastolic pressure was normal. And that is what the discussion was, that sacubitril valsartan now not only does cardiac remodeling, but also does electrical remodeling.
Wow. Right.
And
So
this is what we theorized is because of the reduced left ventricular end diastolic pressure, there was reduced pressure on the left bundle, which now has become into normal sinus rhythm.
wow.
So no LBBB. So he's now on medical therapy, and we have avoided a CRTD in a young male who's 30.
Amazing. Amazing
Beautiful.
story. I think it's great. I think so. So I mean, beyond our thinking as well, there are improvements beyond it. I think absolutely beautiful. I think it's a beautiful case. And Arjun too, is doing great. Again, good, well done medical therapy. Sometimes works wonders. As you very rightly said, I think really aces over it. So just to summarize this case, and then we'll, this is the thing. We talked about heart failure phenotypes, the HFpEFs, the HFrEFs, the importance of NT-proBNPs and where to use and where not to use, and where just, I think great point you said that don't just rely on one, look at the whole picture, look at quadruple therapy. And I think, one star which really emerged, which should have been there, I think it's an oversight. ARNI, right, is the star, the SGLT2 is a star, MRA is very important, beta blocker, especially bisoprolol, which is again a great learning point, is there. I think these are foundational therapies in such patients. SGLT2 has great benefits in such patients, and very importantly, these things improve the quality of life and also ECGs, right? So I think, which is great. So I think great. So just we'll take a couple of questions from the audience, and then we'll end this. We'll allow a few people to unmute themselves. If you just stop sharing. Yeah. So again, from the audience, if you have something you want to share, by speaking, just raise your hand, and we'll allow you to speak while we take a couple of questions from there. Dr. Ramaswamy, Dr. Srinivas has congratulated you for a great CME. Now, I'll tell you, you're a rock star. Okay. It was fantastic. I think a great discussion. I mean, sometimes, just beautiful, right? So Jan has said, starting SGLT2 in heart failure is a little contentious question. You can choose not to answer if you don't want to. DEPA versus EMPA, which would you prefer?
No, see, it's not that. The
Yeah.
question is, if you're doing HFpEF, if you're looking for diabetic control, if you're looking for, see, DAPA is the most studied molecule right now.
Yeah, right.
So all companies are pushing for EMPA, and EMPA is a good molecule. I'm not saying no. So don't don't fix it if it's not broken. So if the
Right.
patient is on DAPA, continue DAPA. If you are having a patient who needs a little more better glycemic control, then you can give 25 mg of EMPA.
Right.
It has a little more diuretic effect. It has a little more better sugar control. But all the studies with improvement in all the morbidity, mortality is all with DAPA. So so it's like just saying which one is more healthier, an apple or an orange.
Yeah. Great.
But see, you can give, and no one can question you either way.
Absolutely. That's a very fair point. I think end of the day, a 10 milligram EMPA, 10 milligram DEPA is nearly the same in terms of data as well, and maybe 25 milligram is a slight pickup benefit in terms of glycemic control, right? Just one last question, Dr. Sanjeev will take that. Inferior wall MI with shock with hypovolemia, right? So what do you do for that? Inotropes, what?
So see, if there's an inferior wall MI with shock, then obviously that means the RCA is affected, or a dominant circumflex, and the artery which is giving the sinoatrial node artery is affected. So the patient will be in complete heart block. Otherwise, the inferior wall MI does not give shock unless complete heart block is there. Or bradycardia is there. That means there is thrombus, synodal artery is being affected, and you have to do something. So the first thing you do is you actually have to put in a temporary, because you have to get the rate up. Otherwise, inferior wall MI doesn't give shock. So put in a temporary, you open up the vessel, get TIMI3 flow. Now, in the acute phase, you give insulin. You don't go to all of this, because the patient is having an inferior wall MI with cardiogenic shock, boss. Okay. So either it's a true posterior wall MI or an inferior wall MI, and there's cardiogenic shock. So you give insulin, tide over the thing, and once the patient is stable, then you introduce the SGLT2 inhibitors, then you introduce everything.
Absolutely.
So you have to learn to triage. You cannot see, medical therapy in the end is like a Cinderella shoe. The guidelines are there to guide you, but you have to make sure which fits the patient and then put that.
Right. Yeah, great. Absolutely. Great point. So I think we had a remarkable session, I'll tell you. We had a lot of fun. So like I said, Dr. Srinivas, you're a rock star. Thank you for this. And I think thank you to Mehul and Siddharth for suggesting. They said, you have to have him on this one. This is perfect for this. I think, it's a great thank you to, Mehul, to Siddharth, and to Dr. Sameer for this. Dr. Sameer, any words of wisdom you want to share?
So I think it was a great session. What I really liked is, although we had a case in hand, Dr. Kudva, I think, shared the real life cases, and that is actually something which is really useful for the attending delegates. So thank you, Dr. Kudva. And this therapy area is really coming up in a long way, something which was not there maybe 10, 15 years ago. And we really need to have a good control on this disease area. That's all that I want to share. Thank you very much, Dr. Om, and thank you, Dr. Kudva.
Thank you so much. So thank you all, and thank you all for joining tonight. And we'll see you. Yes, Mehul, you want to add something? I think you're on a
Yeah,
flight or a
one
mission
of
or
the
something. Yes.
remarkable session I have attended in my last couple of years. Thank you,
Yeah.
Dr. Om, and thank you, Dr. Srinivas. In Chai, you are looking style icon of cardiology
Ah,
today.
yeah, I know. I got a lot of comments today. They're like, "Burp, strawberry." I'm like, oh my God, oh my God.
Great.
Right, sir.
Fantastic, fantastic. So I think
Thank you
thank you
so much.
all, and I think thank you to Zydus for this. And next week we are going to have the nephrologist, so you can grill him about all the UTIs and GTIs you want to. So we'll be taking that. So do join next week for the same. Once again, Dr. Srinivas, thank you so much. Thank you to Zydus, and we'll end the session tonight. And we'll see you next week. Thank you.
And Dr. Om, you're absolutely brilliant. Thank you so much.
Thank you.
And my younger son, who's now 5 months, his name is Om. So I'm
Oh,
naming him.
okay, great,
But
great.
I spell it as AUM.
Okay.
So I put in the Sanskrit ka Om, not the,
Yes. Yeah, my
Uh,
parents always had the choice, but somehow they went with a less number of letters. So I think
yeah.
yeah. So
Anyway,
yes, great.
brilliant.
Thank you.
Good job.
Thank you. Thank
Thank
you.
you. Thank you.
And thank you so much for having me and
Thank you.
for
Thanks.
being here and for our session. And thank you. Good night. Good night. See you all. Bye.